All right, so let's get started here today. Thank you guys for joining us for this week's installment of the Ultrasound lecture series. I'm pretty excited that you could be here and be part of what we're doing. And today we're going to deviate a little bit from our normal course right now, where we've been kind of talking about some advanced cardiac stuff heading into the thoracic realm. And we're going to go backtrack a little bit to the FAST exam. And I had to give a lecture yesterday to our residency about the Pediatric FAST exam to kind of fill something for their pediatric block. And so I thought I'd repeat that again today. I added a little bit of content from yesterday to update it and kind of give a little bit more of a rounded out picture here. But this is going to be the talk that I gave yesterday. We'll do it again today and talk a little bit about the Pediatric FAST exam. So let's switch over to that. So basically, FAST exam in kiddos, right? These are people that come into our emergency department from time to time, and we see them, and they are, they need to be worked up. We need to figure out kind of how the FAST exam is going to perform in them to see if this is something that we can utilize. So just kind of backing up big picture as we think through this, just epidemiologically speaking, trauma is one of the leading causes of mortality in children in the United States. I think that's just a fact. Like if you Google CDC statistics about trauma, or about children, you'll see that trauma is the number one killer. And so if you looked at this article in the New England Journal in 2018, it basically shows that between motor vehicle accidents and firearms, both are traumatic injuries, that it's the leading cause of injury or mortality in children. And interestingly, what I thought was interesting as I kind of looked through this is the distance you are from the hospital, or the presumed distance you are from the hospital, looking at urban, suburban, and rural, really has a huge effect on mortality, particularly in motor vehicle accidents, which kind of makes sense, right? If it takes you forever to get to the hospital for an injury that's potentially salvageable, that was going to affect your ability to survive versus maybe firearms, who are, significantly less salvageable injuries at time zero. So I thought that was interesting, and then if you kind of look down the statistics, not necessarily pertinent to today's talk, but, suffocation and drowning are kind of, main reasons for mortality in children as well. And if you think through it, I mean, toddlers or young children may not have the appropriate skill set to be able to avoid drowning in tubs or pools or things like that, or may not know how to swim. And so that kind of, makes sense on this graph. But really, we want to focus in on kind of the first two aspects here, the motor vehicle accidents and the firearms injury, although that's not really the purview of today's conversation. But in the evaluation of these patients, this is going to be the cohort that we're really looking at, right? Now, what's interesting is this article that was published in 2018 basically showed that in patients, or in pediatric patients who are traumatized, who are injured, right, about a quarter of those patients are going to have some form of traumatic injury to the abdomen, right? And it makes sense, right? About a quarter of the patient's body mass is probably their abdomen. And so if you're going to have some multi-system, trauma, car crash or something like that effect, you're probably going to have some degree of abdominal trauma with that, right? Now, interestingly enough, and our trauma colleagues could probably give us a little bit better, feel on the statistics for adults. Compared to adults, most of these traumas in children are non-operative, right? 95% of these cases end up being non-operative. And if you dig into the weeds in this particular paper, most of these are actually splenic injuries. Although we know that, given kind of the totality of what can happen, various different things in the belly can be injured: the spleen, the liver, the mesentery, the hollow organs like the bowel, things like that. So there's a variety of things that can be injured, but the vast majority of these are splenic, which actually is going to have some interesting implications for our FAST exam. And the vast majority of them are going to be managed non-operatively. Now, the question is, okay, you have a kid who's injured, who's been traumatized, right? There are varying degrees of trauma. And I think this becomes an important factor when we talk about the FAST exam and kind of what we need to think through and kind of how we're going to risk stratify these patients. But these kids are traumatized, right? We need to identify the injuries, because missed injuries, right, they can be potentially problematic. I guess not all injuries are created equal, but generally speaking, a missed injury in the abdomen can be problematic and can lead to excess morbidity, if not mortality, in these children. So we need to have some diagnostic pathway to understand and identify these injuries. And traditionally, we're thinking through the context of CT scans, at least in the adult world. If they have significant tenderness, significant signs of trauma, then a CT scan is the way we're going to go, right? Now, this is not necessarily a benign entity, and we kind of accept that, right? We know that there's going to be some degree of radiation exposure. And for adults, we're a little less concerned, although we want to be concerned about overexposing adults to radiation. But in children, right, who have growing and developing and maturing tissue sets, we need to be a little bit more concerned, right? Because the radiation effects in these children can be a little bit more profound. And in this particular study, I thought it was interesting. They were looking at CT scans in children, and they said for abdominal or abdomen and pelvis CT scans, right? The number of basically the NNT or NNH, I guess, number of scans needed to be performed to cause one solid cancer was about 1 in 300, right? Or one solid cancer per 300 abdomen and pelvis CTs, which to me, I thought was really, really profound. Over the course of a year or so, we'll definitely see a number of children and probably do a number of CTs. And just to know that one of those kids that use CT is going to end up someday having some form of a solid tumor is kind of an alarming statistic, an alarming thing to be concerned about. And so the question that we have is, what do we do about this, right? Do we continue going on and irradiating these children, knowing that it's going to cause some downstream morbidity and mortality, or do we find some other diagnostic pathway with which we can use to identify these injuries in children, right? And certainly it's a risk-benefit analysis. I'm not going to be the one that's going to throw stones and say you should never do CTs, because we have to in some certain circumstances. But you really need to, understand that risk of, okay, what's the risk of the missed injury here versus what's the risk of getting that study? Or are there alternatives that we could use as kind of an off-ramp to help avert that study, maybe a combination of tests or things like that to identify these kids that are higher risk for injury, where their injuries are, and things to that effect. And so that's really the question that we're going to try to answer and see if the FAST exam can actually perform that test that we're looking for. And so as we get into this, let's talk a little bit about the FAST exam. I know this is probably preaching to the choir, and a lot of you guys are very familiar with the FAST exam proper, but let's talk a little bit about that, kind of lay down some of the framework, some of the assumptions that this talk is going to go on, and then we'll dive into the literature after that. And so FAST exam, right? We know this exam. It's basically an exam that's designed to identify free fluid. And so if you think historically, it really supplants the diagnostic peritoneal lavage to look for, does this patient who's been traumatized have blood in their belly, right? And it's really, we need to know that is the main identifying thing that the FAST exam will find, right? So if we're trying to make the FAST exam answer questions that it's not designed to answer, we're really going to come up with a disappointing result, right? And I think this becomes important, as we'll see. So if you're looking for a bowel injury, a mesenteric injury, to some extent, even a solid organ injury, although the FAST exam may pick that up depending on how skilled your operator is, you're probably going to be a little bit disappointed compared to the patient who has free fluid, right? So if you're looking for free fluid, the FAST exam is going to work pretty well, and we're going to see that, right? So that's the main assumption that we're going to have. The other main assumption that we got to think through is, do injuries create free fluid, right? So if the FAST exam is really designed to pick up free fluid, does this injury that this patient potentially have identify free fluid or cause free fluid, and if it doesn't, well, then our FAST exam may have some limitations, right? As we're gonna find out. So those are kind of the two main things that we need to identify. The other thing that kind of a framework to just kind of build in our heads is, as we go through this, right, we need to identify a couple different cohorts of patients with which we can apply the FAST exam to, right? Number one is the hemodynamically unstable. And I think the literature is probably going to be most profound there. But the patient population that we really want to focus in on today is not the hemodynamically unstable, but the hemodynamically stable patient. And in particular, the blunt trauma hemodynamically stable patient. Because you can even make an argument that penetrating trauma has a totally different risk profile in terms of injuries and a different applicability of the FAST exam. So this conversation today, we're going to talk about the use of the FAST exam in blunt trauma hemodynamically stable pediatric patients, right? And we'll further subcategorize that later. But the FAST exam itself, right? Basically, it's going to be multiple different windows, right? So the right upper quadrant window is what's shown here. And this is a typical liver kidney interface, right? The Morrison's pouch interface. And as we know from previous talks, there's places that fluid can collect, right? It can collect subphrenically. It can collect in the Morrison's pouch area between the liver and the kidney. And it can collect at the caudal tip of that liver, with that one probably being the most most commonly positive, at least in adults, in the studies that we've talked about in the past, being the most commonly positive place to look. So fluid can collect there. And in kiddos, it does pretty much the same thing. And the big thing that you need to know about kids in particular is they're just smaller than adults, right? So if you go to your abdominal or your FAST exam preset and just say, go, I'm ready to scan, and pick your probe, right? In this case, we have the phased array probe. But if you do the curvilinear, if they're a bigger kid, just know that since they're smaller, right, you're going to have to adjust that depth, right? And in this situation, we have the liver and the kidney, probably the aorta there, given kind of the trajectory that we're looking. And everything deep to that is going to be wasted space, right? So you want to really decrease that depth, make it a lot shallower to really hone in on the area that we're looking at. It's going to be the main difference with the right upper quadrant for adults and for kids, right? Left upper quadrant, very similar, right? You look at the spleen. Most of the fluid in the left upper quadrant, as we've seen in other studies, is going to collect in the subphrenic area, so between the diaphragm and the spleen. Less so in the spleen in the kidney interface. And then you also want to look at the caudal tip of the spleen. Here's another example of a kiddo, same type of thing. You see a nice image of that spleen. It's very similar to what we see in adults. And just to kind of, we haven't really talked about this graph in particular on this forum, but a couple different ligaments that are really helpful to identify that if we talk to our surgeons, they're going to be a lot more familiar than us as the ED physicians, since we don't really look inside. But the phrenicochoric ligament and the splenorenal ligament are two peritoneal folds that really act as baffles kind of inside the abdomen and going to prevent fluid flow freely between one compartment and the other, and really going to guide and direct fluid around the abdomen in certain ways. And so this is why you don't see as much fluid collecting in the pelvis traveling up the left pericolic gutter and into that spleen area as you do in the right. So if you look here, you can see that phrenicochoric ligament is kind of blocking off that left pericolic gutter, but on the right, it's wide open. So in kiddos, you have a lot of fluid that collects in the pelvis, and that's the most common place that fluid's going to collect in a pediatric FAST, and will travel up that right pericolic gutter pretty freely and dumped into Morrison's pouch, right? The left is not like that, right? In fact, most of the fluid that happens up there is probably originating from near there, right? And it's going to collect in that subphrenic space, right, between the diaphragm and the spleen. And as it travels, it's going to travel across into the right upper quadrant and can spill over into that right upper quadrant preferentially, right? So there's a phrenicochoric ligament. And here's an example of kind of what I was saying with the spilling across. Here's a splenorenal ligament that's identified with that question mark in the line. And it basically blocks off that area, prevents as much flow into the equivalent of what would be the Morrison's pouch equivalent on the left side, and causes it really, you can see it flows, across the anterior abdomen over to the liver side and fills up to the right upper quadrant, right? So that's gonna be the spleen, kind of pretty similar to adults. In the pelvis, again, very similar to adults. You want to scan, and I like the sagittal orientation. Technically, you should probably do two orientations, but I really like the sagittal, sweeping from one side to the other side, basically from iliac crest to iliac crest, including that bladder, and looking through there. And so you see fluid, you can see fluid collect kind of in that, behind the bladder, essentially. And here's another example of a kiddo, probably a little bit of a contracted bladder, since that bladder volume is pretty small. And again, in the pediatric population, this is probably going to be one of the more likely places that you're going to see fluid collect, as you look at these kids in supine view. Now, interestingly, most of the FAST exam, at least the traditional, 3-window abdominal FAST, and then add the cardiac portion, is going to be very, very similar to adults. One thing to note is that it's not uncommon to have a small degree of physiologic free fluid in kiddos, right? Particularly in that pre-pubertal age group, right? You can have some free fluid. And we know this to be true when we're doing the first trimester scans. So you get young women who are in their early first trimester, and you do the transvaginal ultrasound, you see a little bit of free fluid kind of in that posterior cul-de-sac. And it's the same kind of idea, but it's not exclusively related to, to females as well. So in this article that was published in last year in 2021 in Journal of Ultrasound Medicine, it basically said that up to 16% of kids had a small amount of free fluid, most oftentimes seen in the pelvis view. And in the article, they were talking about, a cc of fluid. And I guess it brings up the question is, how sensitive is the ultrasound to fluid? And in adults, historically, we say about 200 to 400 cc's of fluid is kind of what the ultrasound will pick up. But I think in some of these kiddos, particularly if you use a high resolution transducer, a high frequency transducer, like the linear transducer, you can pick up a small amount of fluid. And in fact, here's an example that we had a handful of years ago now, where we saw just this trace whiff of fluid right under that caudal tip of the liver. And you can see in both images, just a teeny amount of fluid, certainly not much. And we perseverated on that quite a bit. And the patient ended up getting CT scan, and they didn't find any injuries and certainly didn't find any significant fluid on the CT scan. So it made me wonder if this is kind of one of those examples of just that trace physiologic fluid that can be seen in kiddos. I think at the end of the day, when you're scanning and they're traumatized and you see a trace amount of physiologic fluid, you have to assume that it's pathologic before you just go back and say, okay, this is normal. But just know in the back of your head that these kiddos can have a small degree, a trace degree of physiologic fluid. And then going to the cardiac window, obviously here's a parasternal long axis view. We can go look at the subcostal. This is a lot less clear in this example, but you certainly can see that there's no effusion there. But I like this parasternal long axis view. It gives you a nice clear view. And since the kids usually aren't that big, it's pretty easy to get to the heart. And especially since the bones, like the cartilaginous attachments between the sternum and the ribs are still pretty cartilaginous, it's not terribly difficult to get into that space. The biggest difficulty that you may experience is the fact that the heart is just so big proportionally to what you're expecting that you may have to adjust your parameters just to kind of see, or to kind of rock back and forth to see the heart in totality. So that's the cardiac view of the FAST exam. So with that being said, right, this is the basic FAST kind of reviewing things. Let's look into the literature. Let's kind of dive in and see, is this something that we can apply in this patient population? And so remember, we're talking about pediatric patients who are victims of blunt trauma who are hemodynamically stable. That's kind of the cohort that we're going to look for. And does the FAST exam help us identify injuries in these patients? And is it applicable to us at the bedside? And how do we make decisions with the FAST exam kind of as we're evaluating these children, right? I think the other thing, and this was brought up yesterday, and I thought it was a really, really insightful point, is as we're going through this, it's probably helpful in our mind to identify a subcohort of this hemodynamically stable blunt trauma kids, and that is the high, intermediate, and low risk, right? The ones you say, yeah, you're in a car wreck, but it's kind of a low risk car wreck. You got no tenderness, you're a low risk category, versus the one who's hemodynamically stable but has profound signs of injury, bruising, seatbelt sign, significant tenderness. Those are high risk, right? And then the intermediate risk of, well, not a lot of bruising, but maybe just a little touch sore when I push on your belly, things like that. So kind of identifying those different cohorts as we work through this, right? So diving into the literature, in 2007, James Holmes, who we'll actually see come back up here later in this discussion, published this meta-analysis of studies that were done on pediatric trauma patients, right? And so basically what this means is that there's a whole bunch of literature before all this that identified, or that they're looking to identify, the test characteristics of the FAST exam. And so it's a meta-analysis of 25 articles, and they evaluated the test characteristics of FAST in kids to identify intra-abdominal injury, right? Or peritoneal fluid. And I think that's a really, really important distinction to make, right? We said earlier that intraperitoneal fluid is what the FAST is designed to look for, and not necessarily all injuries, right? All intra-abdominal injuries. So they're broadening up what the FAST is supposed to be looking for and seeing the test characteristics for that. And I guess it pragmatically makes sense. I mean, the kid's not going to come in and say, I only have intraperitoneal fluid. We're trying to identify any potential injury. So pragmatically, it makes sense, but there's a limitation here in the study, in that kind of going into it, we're already kind of knocked onto the backside of our feet here, just kind of as we're trying to assess the characteristics of this study here. So overall, they found about an 80% sensitivity and a 96% specificity, right? Which isn't bad per se. I mean, a lot of the literature for adult FAST exams show a sensitivity in the mid to high 80s, right? So low 80s for intra-abdominal injuries and intraperitoneal fluid isn't bad. I mean, I could almost live with that. The problem is when they took the more methodologically rigorous studies and reassessed it, they found that again, in these patient populations, the sensitivity dropped down to about 66%. So it's a little over a coin flip. And so their recommendation is that hemodynamically stable, patients with a negative FAST gets a CT scan, right? And so I don't know, it's a little bit of a disappointing study to kind of start off on. So in 2000 and whatever year this was published, it was later than that, Chris Fox and his colleagues out at UC Irvine published this study looking at the test characteristics of the FAST exam in pediatric blunt trauma patients. And so they basically did an analysis of kids from 2004 to 2007, right, with blunt trauma who received either a CT or a laparotomy, and compared those findings to the FAST exam to say, okay, how did it compare, right? Did the basically the CT find clinically significant free fluid, or the laparotomy find it, and how did the FAST, compare with that? And they found basically a sensitivity of 52%, right? Specificity is about the same. And when they looked for any degree of free fluid, not just clinically significant free fluid, the sensitivity dropped down to about 20%. So again, a little bit disappointing on the sensitivity side. Again, another meta-analysis that was done more recently in pediatric emergency care by this study group was looking at the utility of ultrasound, essentially, to assess for intra-abdominal injuries. Again, intra-abdominal injuries, all injuries in kids with blunt abdominal trauma, right? And they evaluated the test characteristics and said, hey, look, you have about a sensitivity of 35% and the specificity of about 96%, right? And they actually did it was kind of unique. They did some analysis to look at test thresholds to say, okay, once I've done the FAST exam, does my post-test probability for a positive FAST exceed my threshold to say there's enough of an injury, where I need to scan them, CT them, or does my negative test get me below a certain threshold to say I don't need to scan them, right? And so for the positive side, a positive test basically got them above that threshold, saying, I'm reasonably convinced that there's an injury, right? That a CT scan would have picked up for a post-test probability. For a pre-test probability or a post-test probability of negative, it only got you down to about 9%, which most people would consider pretty unacceptable to say there's not an injury in this cohort of patients in a negative FAST exam. So again, kind of the summary of all of these studies put together is that the specificity is great, right? In blunt abdominal trauma, or in kids with blunt abdominal trauma, where you're trying to identify whether there's an injury, if you see a positive FAST, there's an injury, right? There's something going on there. If you see a negative FAST, it's really hard to make that assessment to say, yeah, there's definitely nothing going on, right? You're going to probably have to continue on digging in this patient in some capacity, right, to help add sensitivity to your FAST exam. Now, I thought this study was interesting. This was done by Holmes and colleagues as well. It was done more recently. I think it says 2017. And they basically identified 925 kids, and they randomized them to FAST exam plus standard care, or just standard care alone, right, without FAST exam. And what they wanted to do is identify, is there any difference that the FAST exam provides in terms of clinically meaningful outcomes, right? And so they took 925 kids, right? They found that 50 of them had some form of abdominal injury. 40 of those kids, so most of the kids, 80% of those kids, had abdominal injury associated with free fluid, right? And 9% of them got some procedural, laparotomy or surgical intervention, right? And if you compare the test characteristics of the FAST and the control group, they found a very similar ED length of stay, very similar rate of CT scan performance, and very similar hospital charges. And they actually said, well, there was one missed injury in the FAST exam group. And so their conclusion is, well, we don't think this FAST exam is such hot stuff. There was a couple, letters to the editor or commentaries written about this article. And one of them was by the folks out at Yale. And I thought it was pretty insightful. And I tend to kind of agree a little bit with the Yale folks in terms of their analysis here. They were pretty critical of, some of the findings, and said, hey, look, okay, this missed injury thing, if you look at the details, the missed injury wasn't missed by the FAST exam. It was missed by everything that was done in that patient in that FAST plus usual care, including the CT scan, to identify, what's going on here. So you really can't blame that one entirely on the FAST. And they were also making the point of, okay, so negative FASTs don't necessarily give us a lot of sensitivity, right, in terms of our analysis of these patients, but there's a lot of unmeasured effects, that the FAST exam will provide, right? And one of the big ones that's unmeasured that they really commented a lot on is, hey, in order to be good at something, you have to do it, right? So we don't go into our first intubation on the critical patient and expect to be doing it well, right? We don't drop our first central line on the crumping patient who's got a blood pressure of nothing and no preload, right? These are the hard patients. And the only way to be good and prepared and ready to do those is to do lots of whatever procedure that is on a lot of different people, not unnecessarily, but do a lot of studies to get comfortable so that when when the critical one happens, when the time is right, you're good, you're skilled, and you're proficient at doing the one that you need, right? And so their big argument was, we shouldn't throw out the baby with the bathwater, no pun intended in this situation. We shouldn't throw that out. We need to continue to do the FAST exam so we can be good in the ones that, is going to have a bigger impact. My particular analysis of this study is, okay, I accept these, but you've picked 3 of the potential impacts that the FAST exam can have on clinical care. And there are a lot of other impacts that this FAST exam can have on the management of the patient that are not measured specifically in, did we find the injury and did it decrease time, change costs, change the CT rate. And one example is you've got a multi-systems trauma. They're hemodynamically unstable. The blood is somewhere, right? Assuming that this is purely a traumatic hypotension, right? And I guess we're talking about unstable a little bit here. But, is it in their head? Is it in their chest? Is it in their, around their heart, in their belly, the pelvis, retroperitoneum, in their thighs, and the floor? The FAST exam really can look at a number of these different places to help identify where exactly that blood is and really start your resuscitation, or say, hey, look, it's not blood at all. It's the tamponade physiology or attention physiology, and really guide and direct kind of what procedures need to be done next. And so those are all unmeasured effects of the FAST exam. None of these studies really pick up in this patient population, right? Now, one other interesting study was this one was looking kind of more at the hemodynamically unstable cohort, right? And so they basically found that most of the cases or most of the patients who had, actually, they were looking at is like, does the FAST exam portend like, or identify who needs to go to the OR earlier? And they basically found a high degree of specificity for early identification of patients who needed to go to the OR, and that a lot of the patients who went to the OR had a positive FAST exam. Right now, there's some caveats to this one. Not all patients go to the OR, right? Not all patients get some procedural intervention. And so there's unmeasured effects and some limitations here, but it kind of shows a little bit more utility in the hemodynamically unstable patients. So the question comes, how do we improve these test characteristics, right? Are there things that we can do that really change that number, that sensitivity number, to make this more of a meaningful test for us, right? And so there's 3 things that, that I've identified, and there's probably more, but 3 things specifically I wanted to talk about here. Number 1 is just doing serial exams, right? If we know that doing something over and over and over again increases the likelihood that we're going to, find something. I mean, it's kind of that principle of a blind squirrel will eventually find a nut, right? It seems a little bit maybe jaded to say it that way, but we do this in other contexts and call it legitimate medical care in other ways, right? We have that patient who comes in with concerning sounding chest pain. Their first EKG is abnormal. What do we say? Hey, get me another one in 10 minutes and let's see how it looks, right? We certainly had a case like that recently where we watched the EKG over the night, and none of the tests individually were none of the individual tests were diagnostic of coronary disease or intervenable coronary disease. But when you kind of watch that aggregate change, eventually you see kind of that EKG change, and it kind of makes that diagnosis for you. And the same is true here, right? If you do serial exams, you increase the likelihood that you're going to pick up something, right? Especially as this is an evolving process. And maybe part of the sensitivity is the fact that it just didn't bleed enough to see it the first go around. And once you do this again, you may see it later. Or when you push on the patient's belly again, kind of do those serial abdominal exams, you're going to pick up some, new tenderness or new sequelae of their injury, right? So that's number 1, serial exams. Number 2 is just adding labs, essentially. So this was a study that was published not too long ago that basically said, hey, look, what is the sensitivity specificity of doing ultrasound to identify these injuries? Now let's add LFTs, right? And see if a transaminitis changes that. And so what they found is that the sensitivity specificity of the ultrasound alone was about what we'd expect. It was like 50s and it's in there somewhere, not like 91% specific. But when you added LFTs, that changed things. And again, this is in blunt trauma patients under the age of 16. So adding LFTs and having abnormal LFTs increased your sensitivity to 88% essentially, and your specificity remained high at 98%. Right. So this is an interesting thing to throw in there, kind of increases that test characteristics. Now you're missing a whole lot less. The problem I have with this one is, okay, but not all intra-abdominal injuries are hepatic, right, or present with hepatic findings, right? A solid or not a solid, hollow organ injury, in the bowel, a small bowel or large bowel, can present with, or may not present with the abnormal LFTs, right? A mesenteric injury may not do that as well. So different things that you can have where this would be a little bit limited, but it does increase, at least statistically, the sensitivity of these patients. Another one is, what about doing urine? Looking for hematuria to look for potential renal injury. So at least we could throw another organ system in there, right? And this was a study that was done not too long ago. That basically showed ultrasound plus a UA had about an 85% sensitivity and a 92% specificity looking for injuries. The only problem I have about this study is that they were very unclear as to the methodology of what ultrasound they were performing. The title says FAST exam, but then they kind of leave it as that. They don't really further describe it in their methods. And in their methods, they say that they are performed by radiologists. And so there's going to be some limiting factors there. Now, I'm not one to say that ED physicians are inferior to radiologists when performing the FAST exam, but there are some limitations in terms of just operator experience. If their protocol was slightly different compared to what we do, and so it may not be a direct one-to-one correlation, but it definitely shows a better sensitivity when you add in that test. So what conclusions can we draw? Right, the FAST exam is basically a highly specific test, right? So if you see free fluid, great, you've got some free fluid. That free fluid in this population is probably related to an injury, right? But the FAST exam is poorly sensitive by itself for intra-abdominal injuries. Remember, like intra-abdominal injuries writ large. So all of them in this cohort of hemodynamically stable patients with blunt abdominal trauma, right? So the question is, now what, right? We just spent the last, half an hour talking about ultrasound. This is a forum that praises the, how great ultrasound is and teaches us to do ultrasound, right? And we just spent the last half an hour saying, yeah, but maybe not, right? So what do we do with this information? And more practically, when we go down to the bedside of the patient who's going to come in today or tomorrow or next week, and they have some abdominal tenderness, what do we do with that, right? Do we just throw this out and say, that's worth it, we're going to CT scan the patient anyway? Or do we do the FAST exam and make decisions off of it, right? So a couple things. Number one, perform the FAST, but know its limitations. And when I say this, I think it's helpful for us to identify really those three categories: high, mediate, or low risk, stable, blunt abdominal trauma patients, right? So high risk patients, they're probably going to need a CT scan no matter what we do, right? Low risk probably won't, and we could probably utilize the FAST plus some of these adjuncts to help make that low risk. And the intermediate is the one where we're going to have a little bit more more room to kind of have conversations, about the test characteristics and talk to the parents and things like that. And so one of the strategies we talked about yesterday was, hey, do the scan, right? If they're in this low to low intermediate risk, do the scan, get your adjunctive labs, push on their belly a couple times, and then have a conversation with the parents and say, hey, look, the test we did has about a 85 to 87% or 88% sensitivity to rule out injuries. Not perfect, but the alternative is to do a CT scan and irradiate your child's belly. What do you think we should do? And kind of have that conversation with parents. And here's the risks of doing the scan. Here's the risks of not doing the scan, and kind of making that conversation happen, especially kind of as we add serial exams and some time to that. So that's kind of one of the things that we were talking about. So know the limitations of the test. Know that when you do the exam, it's not necessarily going to be, 100% specific to or sensitive to rule everything out. And I think it's also helpful to know, kind of in that whole framework, none of these exams really risk stratify the children, right? They basically said, we're looking for any injury. So this whole positive category was low to high risk patients, and didn't really risk stratify that. And so I think it's hard to kind of interpret that the low sensitivities in the low risk population because of that lack of risk stratification. So there's room for conversation in that capacity, right? Secondly, do things that add sensitivity, right? So we talked about the LFTs, we talked about the serial exams, we talked about the UA, kind of add those things in to increase the sensitivity of your FAST exam, to give you a little bit more confidence that you are, you're actually dealing with a low risk child, not, someone who's a high risk for injury, right? 3, if concern for intra-abdominal injury persists, you're probably just going to have to bite the bullet and go for the CT scan, right? As much as I'd love to say this particular application of the FAST exam is the best thing since sliced bread, at the end of the day, for blunt, stable patients, who have concerning findings for injury, bruising, tenderness, seatbelt sign, etc., you're probably just going to have to get the CT scan. I hate to admit it, right? Number 4 is don't forget the EFAST, right? So we talked about unmeasured effects of the FAST exam and how it's not necessarily doing only what these studies have said it's doing, right? There's a lot of things that we do to kind of help risk stratify the exam. And I guess a really silly example here is, what's the sensitivity of pushing on someone's belly to identify injuries? Probably really, really, really low, right? I could have had a really bad turkey sandwich and then go crash my car. Maybe my stomach is hurting because I didn't like that sandwich compared to the trauma, right? So we don't throw out the fact that we push on the patient's belly just because it's got a low sensitivity, but we use that to kind of help guide and direct and say, this is where we need to focus our time and our attention in other diagnostic studies. And that's really the effect that the FAST exam doesn't have measured in some of this literature, is how does this help either guide and direct life-saving adjuncts in the trauma bay, or focus our mind's attention to something so we don't get anchored somewhere else. So don't forget that. Don't forget to expand it into the thorax, where the test characteristics are a lot better, right? So looking for fluid in the chest, looking for pneumothorax, right? We know that the sensitivity of a supine chest x-ray is really, really awful to identify for pneumothorax, but really, really good to identify with ultrasound, right? So those test characteristics don't change regardless of the abdominal injuries. So, expand your EFAS indications, in these patients, to kind of liberally use that to kind of cut down radiation in other capacities, right? And don't forget that there's a totally different paradigm for hemodynamically unstable patients, right? If you have a hole in your belly, the FAST exam is applied differently, right? We could argue whether or not a GSW to the belly, in a pediatric patient wouldn't warrant just automatic admission to the OR versus CT scan to identify, the injuries. But you can say, hey, look, in a penetrating trauma, do we have free fluid? Is something injured on the exam? That's going to raise and lower our suspicion to kind of know what we're looking for. In hemodynamically unstable patients, where's the fluid? What do I need to first intervene upon? Is it the chest? Is it the pericardium? Is it the peritoneum? And then definitely penetrating trauma to the chest. I mean, that's a totally different paradigm. Like, the FAST exam is almost mandatory looking for free fluid around the heart. So remember, these test characteristics apply to blunt, stable, not these hemodynamically unstable or penetrating trauma patients. So that's kind of the FAST exam in pediatrics in a nutshell, kind of what the literature shows in ways that we can kind of increase the test characteristics of the FAST exam. So that being said, are there any questions that you guys have? Any comments? I know we have someone from the trauma service here. Any comments from the trauma side to round things out, or anything that you want to add to this conversation?